the spectrum may have a more interest in their own activities, the things that interest them, but that lack of social reciprocity is another one of those things that we really look for. As children grow from toddlerhood into early childhood, let's say the ages of 3 to 5, approximately, their social interactions, typically developing kids, really grows, and they want to play with other children. They want to get together. They'll sing songs together, particularly in any kind of organized setting. If there's an adult, we're going to sing this song, we're going to do that activity, and they love doing things together. There may be a circle, song, and dance that we do together. All of these things are typical and fun for kids, and they begin to enjoy games. The younger they are, the more simple games, but as they grow older, they may be interested in more sophisticated games. They develop preferences in terms of friends, even though that is fluid throughout life. There's someone that they prefer to play with, or some children they prefer to play with. When there is a lack of interest in those peer relationships, again, that's another one of those things that we should be concerned about to try to understand. We would expect to see that interest with parents, with siblings, with immediate family, and then as the child grows older, with peers. And when that's not there, we have to note that and begin to think about that. It's important to remember there's a big difference between a child who is shy and a child who is disinterested. We've all seen shy children. Shyness is not what we're talking about. Additionally, sometimes we can see children who are anxious. They're cautious, and that doesn't mean they're disinterested. It just means that they are careful, cautious, shy. The language that I frequently use for those of you who are familiar with computers, and I am minimally familiar with how computers work, is that for many of these kids, it's as if the software for relationships didn't quite get downloaded. Now, that's obviously not a neurological definition. It's my own definition, but I think it captures descriptively what kinds of things that we might wonder about when we see children who are not developing their social relationships. One of the other social deficits that children may display is a lack of make-believe play. So for example, if you have a child playing with a doll and the doll becomes like a real baby, or they have a toy car and they're making believe that the car is going down the road saying zoom, zoom. I believe the word might be agula, where they're making believe that this little toy that they have in their hand is really a car. Frequently, children on the autistic spectrum don't or can't display those kinds of make-believe behaviors. They may play with a toy, but with some frequency, they're playing it in a way that is not attributing the symbolism to the toy, as opposed to playing with a toy as an object. And by that, I mean, again, this is a classic thing that I've seen more times than I can count. That toy car, instead of going zoom, zoom, and now we're going to the store, or now we're going to visit grandma and grandpa, they may take the toy and they may just look at parts of it, or not uncommonly spin the wheels of the car and just look at that in a way that is a bit unusually fascinating. We talk about an understanding of social cues. That's another area that children with autism commonly struggle with. This would include reading and correctly interpreting eye contact, nonverbal behaviors, body language, nonverbal communication. My favorite example of the kind of thing that most typically developing children get is when they might be misbehaving, or they might be doing something that is not what the parent wants them to do, and the parent gives them that look, that harsh, disapproving, no words, just that look. And the child looks at the parent and gets it. They get that they've disappointed the parent, or they get that they've messed up, that they've made a mistake somehow, that they did something they shouldn't have done, and they burst out into tears. Most of us have seen that. That is a wonderful example of a child who correctly reads nonverbal communication. A child with autism may not get that at all. They may not have the eye contact. If they look at you, they may not understand that disapproving look. Important to remember that if a parent gives a child a disapproving look, we're not talking about the child, whether the child's being compliant or not. We're talking about whether the child sees it and understands. There are plenty of children, and this is a normal developmental stage. There are plenty of children who will look at you, see that you're saying with your eyes, with your face, don't do that, and they do it anyway. That kind of oppositional behavior is not uncommon, is pretty normal. The difference between that child who sees it, gets it, and does it anyway, and the child with autism is that the child got it. They understood what you meant and they didn't do it. As opposed to a child with autism who may do it, but they just may not get in reading your face that you didn't want them to do it. Let's move to the next slide. We're going to talk about social communication and interaction, days of interaction. There's very commonly a lack of speech and language development in children with autism. When I was working at the Marcus Autism Center, I did many hundreds, thousands of assessments of young children. And I knew what to look for. And with some frequency, by the time I had walked out to the waiting room and walked them back to my office, just observing the child in that short interaction, I had a sense of where we were going, because they may not have been engaged. They may have held mommy or daddy's hand and come with. They may not have had any words. Sometimes the lack of speech in little children is a very loud, bold symptom, because little children, when they begin to acquire language, they speak all the time. They're chatterboxes. Look at this, I see that, now we're going here. And when a child does not do that, it is very much concerning. The time for children to use, I'm going to talk about language acquisition for a second. Children typically use single words, regardless of their mother tongue, whether it's Amharic, English, French, regardless of what it is, by about the age of 12 months. Some children start earlier, some children start somewhat later, but 12 months is about the time that children will use simple words: ball, dog, mommy, daddy, more. And of course, the classic, and I suspect also cross-cultural first word that many children learn is no. When a child is unable even to approximate the word, for example, in English, if they say ba for ball, and I believe in Amharic kwasi is the word for ball, and so any partial use of the word ball, again in Amharic or any language, may be developmentally appropriate. If the child at 1 in English is saying ba for ball, that's great. They're using language. They know that it means that round object. That's great. It's gonna develop, typically speaking. Pointing is another way of communication. If a child points at something that they want or they like or that they're seeing, that's a communicative behavior. If the child points at the ball and screams, we would rather them say, "Mommy, can I have the ball?" But pointing at the ball and screaming, or pointing at the bottle at screaming, or at wanting to be fed and screaming, that can be communication. We accept where they're at, and then we begin to massage that so that they're saying full sentences. When this is not happening, again, single words by year 1, and typically 3-word sentences by age 3, at the very least. If those things are not there, it's a very significant area of concern and really indicates the need for some further exploration. Children by age 3, they're usually using 3-word sentences. I want more. Can we go? I'm hungry. I want that. They also tend to mimic adults. If we're going to go outside and mommy or daddy says to the 3-year-old child, "Do you want to go for a walk?" or "We're going to go for a walk now," the child may very appropriately repeat, "Go for a walk." That can be seen in children younger than 3, but certainly by 3, we expect that kind of communication. Again, the lack of that communication is something that we want to be that we want to note, and we want to try to encourage. I mentioned earlier the use of atypical speech and language, which is sometimes a more subtle behavior that can be more difficult to discern. Some children with higher functioning autism have no problem with speech acquisition at all. They learn the language, they're using it really, really well. Sometimes they're very advanced. Sometimes they begin language acquisition from an early age. But one of the things they often do is they may not have the common syntax, meaning they can have difficulties using typical words in a sentence the way the language is normally structured, the way the words are ordinarily ordered. These children might have, and in higher functioning children, they might even have a very unusually sophisticated vocabulary. Sometimes they're described as little professors, but sometimes the symptoms are somewhat more subtle. We'll speak more about that next week. Again, in the area of atypical language development, echolalia is a common behavior that's displayed with children with autism and similar developmental delays. Echolalia comes from the word echo. It's when they're repetitively using words, phrases, or maybe even long texts of stories, books, or videos that they might see. It is very common to see children parroting back long segments of dialogue from a book or a movie or a cartoon that they have seen. And what I want to distinguish is the difference between that, which is seen as a self-stimulatory kind of behavior, and we'll talk about that in a moment, and a typically developing child who may say the same things, but it's in context and it's within the desire to connect socially and to communicate. So if a child says, I see a bird because there's a bird flying by, they may say that same sentence to you a lot in the minutes after they see the bird, or every time they see the bird, they may say, point and say, I see a bird, I see a bird. What's the boundary between typical use of that language and atypical use of that language? And I think the boundary is when the child is trying to, as I said earlier, when the child is attempting to share with you. They're trying to connect with you, and they're trying to they're not just repeating the words because they enjoy repeating the words. Sometimes that's not unusual for small children who are just learning language. But once language is established, they tend to not do that so much. And if they do, it may be in play, in jest. In a similar way, most parents have seen this, that a child may want to play the same game over and over and over again to master the tasks involved with that game. They may want to have the same book read to them over and over and over again, admittedly, sometimes to the chagrin of parents. I recall that when my children were young, and I got very tired of reading the same books over and over and over again. But that's how kids master their content. So the use of this repetitive language in echolalia is something that, again, we want to note it. We want to be a little bit observant to see, is it a connecting behavior or is it repetition for repetition's sake? And if it falls into the latter category, it's another one of these things that we want to note, we want to discuss with our care providers. And as I know we have many doctors and psychologists, teachers, as I mentioned before, it's a good question to ask the parents if they're seeing signs of echolalia, because that can be an important diagnostic or developmental milestone. Again, I'm going to just go back to this use of the word spectrum. There are many different etiologies that may be responsible for a child who is not speaking. There are developmental language disorders. I mentioned anxiety before. There are speech impediments. We have to, as professionals, as parents, we have to understand that there may be more than one etiology for some of these things. And I caution people from saying, oh, if I've heard professionals say, well, the child's speech and language is fine, it can't be autism. Or the child's eye contact is fine, therefore it cannot be autism. I think that those sorts of all or nothing, black or white sorts of conclusions, I think we need to be cautious about them. Let's go to the next slide. Restrictive, repetitive, stereotypic is the word that's used, behaviors that have a self-stimulatory function. Classically, children with autism have a variety of these repetitive, stereotypical behaviors. And when we're thinking about these, we think usually about the five senses, right? What are the five senses? You remember this, I'm sure, from elementary school. We see, we smell, tactile, we touch, we hear, and we taste. Some or even many or all of these areas can be an unusual focus for children with autism. They may listen to certain phrases electronically in a repetitive fashion. They may, if they have an electronic device, they may rewind and replay the same phrase, the same dialogue over and over and over again. That would be an auditory stimulation. Or they may stimulate visually their sight. I've seen children, and again, this is a great clue that you may be dealing with a child of autism. If they're taking something, even their fingers, and moving them in front of their eyes repetitively, they may be fascinated with certain smells or tastes. And again, we talked about hypo or hypersensitivity. It's not uncommon for children with autism to have a sensitivity for the textures that are in food. They do or don't like, and this is more than like. This is like a very, very distinct, almost inability to tolerate foods of certain textures. It may be soft foods that they do not eat. It may be high texture foods and things that are crunchy that they cannot tolerate. You'll see many different variations. That's a sense of touch within the mouth. They may touch certain things repetitively, or be very, very upset about the way certain clothing does or doesn't feel on their body, or socks on their feet. They have to be just right, or only this sock, or only that fabric. Their fascinating with taste or smell may become very severe. I've seen children who eat feces, as disturbing as that is. And the way we understand that is that it's such a sharp, strong taste that it's stimulating for them in some ways. A lesser gradation of that same behavior is you may see children who like very spicy foods or very sharp foods. I believe in my reading that the Amharic palate often has more spicy foods in it. I think India does as well. So that may be less of a clear sign socially. We always want to try to understand what's the function of these behaviors. Functionality is a classic behavioral analysis term, which we'll talk more about in the coming weeks. We want to know, like, why is this behavior? What does this behavior accomplish? Children classically may not hug. They may not like physical touch. Or they may really enjoy strong massage, strong hugs. So these kinds of sensory stimuli are important things to look at and kind of keep on your radar screen, so to speak. Sometimes, sadly, self-stimulation can go to very harmful extremes. I've seen children who have enucleated their eyeball. They literally took their eyes out of their eye socket. I've seen deep biting where a child that I worked with had chewed his arm from his shoulder where he could reach all the way down to his hand. And his arm really looked like chopped beef. It was quite disturbing. Obviously, these kinds of behaviors, particularly when there's significant tissue damage, is the kinds of things I've just pointed out, they must be intervened with. They're urgent. That being said, most self-injurious behaviors do not involve tissue damage or very mild tissue damage. It's not uncommon to see a child who might have an excoriated spot on their hand when they're biting, and they may bite their hand over and over and over. They develop a callus. It may become raw. It may become even cracked and such. That's tissue damage, but it's on the much milder end of things. So we have to bear in mind that disturbing as these behaviors may be for parents, very understandable, we do have to assess what level of tissue damage is there, because we have to be mindful about what does and does not require intervention, and also how to execute that intervention, because intervention for these kinds of self-injurious behaviors can be a very, very challenging thing to accomplish. Children with autism can be very focused on routine and ritualistic behaviors. They may require certain sequences. They may be very inflexible. They may be very rigid. Whether that has to do with their morning routine, that they have to do things in a certain order, or it may be about their food, that the food has to be only these foods, or it can only be on the plate in certain ways. It's not uncommon, by the way, for typically developing children to not want their food to touch, but that's commonly a phase that children get through. And if the only thing that a child displays is a finickiness, a pickiness about their food, and they're developmentally normal in every other fashion, so it's a data point that doesn't necessarily connect to anything. So we have to be mindful of that too, of not overlooking at one thing, but rather looking at the big picture. They may take toys, and instead of playing with them the way they're intended to be played with, they may line them up in long lines, which is inconsistent with the way that many of these toys are meant to be played with. So we have to be mindful of these things as well. Particularly children with high functioning autism may have an unusual focus on a limited range of topics. They also may have an unusual understanding of these topics. I've heard children with high functioning autism who know more kinds of dinosaurs than I ever knew was possible, or they become fascinated with archaeology, and they have an understanding of some of the most arcane minutia of these topics. That is its own data point to note, because that, again, you may have a child who's a genius, but that level of genius is much less common statistically than a child with high functioning autism who just has an unusual penchant for these kinds of data that they are collecting. They may not be able to discuss anything except their preferred topic. And once you're talking about their preferred topic, they're very happy. But if you try to change the topic to something else, they are unable to do so. Let's go to the next slide. I'm aware of the time. I'm gonna try to, and we got started a little bit late, so I'm gonna kind of squeeze in everything I can in the next 5 or 10 minutes or so. So if you have a child where you've got these concerns or some of these concerns, what do you do? For the physicians, for the psychologists, the medical personnel who are listening, they know appropriately that a medical screening is really the first stop. We want to make sure that the child is hearing properly, and we want to make sure that they're seeing things properly. The worst thing in the world to do is to miss a child with a hearing loss or a visual impairment and jump to a mental health diagnosis. It's simply said, it's not good practice. We want to make sure those things are done. We want to know if there was any prenatal or perinatal trauma. Was there prenatal care? A neurological exam should be performed. Genetic testing may be indicated. While there's no genetic marker for autism, there is for things that present in a similar way, things like Rett syndrome, which used to be included in the DSM-4 under the umbrella of autistic spectrum disorders. Fragile X syndrome can present with autistic-like behaviors, and there may be a comorbidity between Fragile X and autism. Thyroid levels should be tested, lead levels should be measured, basic metabolic and nutritional screening should be assessed. It's not uncommon for children with autism to have gastrointestinal complications that may need its own separate GI assessment and treatment. So the medical screening is very important. It's best if the physician who's assessing the child have some familiarity with developmental disabilities. Some medical issues can be either contributory, as I mentioned, or even causal to the presentation of autism. But there are many comorbid, concurrent conditions, such as children with seizure disorders, genetic disorders, as I said, cerebral palsy and autism can commonly occur together. I know one of our parents here has a child with Down syndrome. There can be a frequent comorbidity between Down syndrome and autism. It's very common for these children to have attention deficit disorder, anxiety disorder. So it can be confusing, and that's why it's important to have a medical professional who knows what they're doing take a look at these kids. Let's go to the next slide. Once all of these bases have, once all these things have been checked, it is proper to pursue a psychological formal diagnosis. And there are a number of psychological measures. The psychologists in our audience will be more familiar with these things. Really, the gold standard is the ADOS, the Autism Diagnostic Observation Schedule, and the Autism Diagnostic Interview, ADI. These help look at a child with autism from many different angles, from the parent's angle, from the interviewee's angle, maybe from a teacher's angle. There are other well thought of instruments, the CARS, the Childhood Autism Rating Scale, the SRS, the Social Responsiveness Scale, the GARS, the Gilliam Autism Rating Scale. Finding a clinician who's familiar with these instruments is very valuable and can really help differentiate the diagnostic issues that we're looking at. Children may need cognitive evaluation as well. Children with speech delays may be hard to assess with some early cognitive testing, because so much of that is speech based. a qualified psychologist can help discern how to accomplish these assessments and what is or is not cognitively involved, because cognitive delays can be another very common comorbid phenomenon with autism. So just to summarize, and I'll wrap up and then I'll welcome questions if you have them. We've just reviewed briefly the issues involved in understanding what autism spectrum disorders are and how they present. We've discussed the classic presentations with the broad delays in area of child development, the pervasive areas, which is social communication, social interaction, speech use and acquisition, atypical, repetitive, and sometimes rigid self-stimulatory behaviors. They can be mild, they can be very, very severe. The mild ones obviously sometimes being more difficult to assess. In our next meeting, which I hope you'll come for next week, we're going to discuss early intervention, what it is, what its values is, and we're going to answer what I think one of the most important questions that's often unasked when working with children with special needs, particularly children where the diagnosis is unclear or difficult to assess for whatever reason, which is, does a clearly defined diagnosis matter? To what extent does a clearly defined diagnosis matter? We'll discuss that more in detail next time. I'm happy to take questions and look forward to seeing you next time. Thank you so very much for coming, and I'm excited to see and participate in what Ayin is offering the Ethiopian community.
Thank you so much, Moshe, really. I wanted to know if there are any questions here. If so, you're welcome just to unmute yourself and ask. Any questions? Okay. I don't see any in the chat, so I think we're just
I see a number of them in the chat.
No, they're just chats. There aren't any questions.
Oh, those people talking to one another. Okay.
Yeah. So first of all, I want to thank you for taking the time to empower us with such valuable knowledge. I hope your contribution makes a real difference in the way individuals with autism and their families are supported in Ethiopia. I would also like to thank all of you here for participating in this new and exciting journey, and remind you to please help us by filling out a short questionnaire that I also posted in the chat, and also will send via the email a link that I would really like you to fill out, that will help us understand better where things are now in Ethiopia concerning autism.
So I see, pardon me for interrupting. I
Yeah,
see
sure.
there is one question, and Dr. Marone looks like he is about to ask
Oh,
another, and we welcome
okay.
that. Dr. Marone, Yodit asks, is there any chance that an autistic child gets totally gets better? Autism as a neurodevelopmental disorder is understood as a chronic condition. There's a lot of things that we can treat. There's a lot of things that we can work on, and we certainly see improvement in many children in many areas. We don't necessarily talk about curing autism because it's not a distinct sort of discernible medical process as, for example, appendicitis or kidney disease. You can measure that. You can give certain medications for kidney disease. The kidney can get better. We can do a kidney transplant, all sorts of things. Autism is not like that, but there are many symptoms of autism that we indeed can treat. And we're going to talk about that more next time, Yodit. Dr. Marone, did you have a question? Feel free to unmute yourself if you'd like to ask. Maybe he's changed his mind, or she's changed her mind.
Maybe.
Here we go. After the first evaluation, after a diagnosis is made, when do we reevaluate? That's a really good question. Reevaluation in some, well, there's I have a couple of answers, of responses to this. It's a very good question, Dr. Murad. You can have formal, Elon Musk, okay. That's Yodit. I'll talk about that. You can have formal psychological evaluations over time. Those can be very good markers, particularly in terms of cognitive skills, to measure over time. On a practical level, in terms of behavior, parents know these things. They can tell pretty quickly whether or not a child is or is not progressing. So there is an ongoing sense of evaluation, formal measures such as cognitive cognitive levels, as I said, they can be measured over time. So I'm going to comment to you, Yodit, who asked about being cured because of Elon Musk, who allegedly has high functioning autism. I don't know much about Mr. Musk's clinical presentation. Being the richest person in the world, certainly, his autism certainly was not an impediment in that area in terms of his brilliance and his success. But it's very unclear to me. I don't know anything about his early childhood, what level of impairment he did or did not have. My guess, and I'm only guessing here, is that given the very little that I know about the man, is that he would fall into a category of someone with high functioning autism. And frequently people with high functioning autism are not diagnosed early. There was an 18-year-old young man that I saw who very clearly had high functioning autism that wasn't, and this was in urban Atlanta, Georgia, America, and he had never been assessed as having high functioning autism, which shocked me, but that happens as well. The Juanos is asking about ASD and IDD, comorbidity and diagnosis assessment. I'm not sure what IDD is, what the intellectual developmental is. I'm not sure what IDD is. Juanos, can you spell that one out for me? There it may be something that I'm unfamiliar with. Renana, are you familiar with IDD?
No, I was also trying to think when I saw that question. Yes.
Oh, intellectual
development.
Intellectual developmental disorder is I suspected that. When I use cognitive delay, cognitive impairment, they're the same thing. So there is in lower functioning people with autism, IDD, cognitive delays are common. That's why I mentioned earlier that a well-trained psychologist is needed, because so much of what is used to assess those things, you have to be very cautious and careful. You don't want to jump to conclusions. And this is why we have well-trained psychologists who assess intellectual disabilities, cognitive disabilities, formerly called, doesn't tend to be called this much anymore, but it's many people are familiar with the word mental retardation, where it's more descriptive, it's not used as much these days, where their mental capabilities are retarded meaning slowed down. So I don't have off the top of my head what percentage of people with autism have cognitive delays. And I apologize for that, but it's not insignificant. There are many children who are lower functioning on the spectrum who have very distinct cognitive impairment.
Moshe, I'm gonna stop you since it's already almost 11:15.
Yes.
Juanos, I see you had a question here about high functioning autism and autism savant.
We're going to discuss that next time.
Exactly. So that's what I wanted to say. That we'll discuss that next time. So you'll just have to be patient and wait. So again, I want to thank you, Moshe, very, very much for this lecture and for the next ones coming. Hopefully we'll see you all next week on Thursday, the 22nd. And again at 10 a.m. I posted here the link to the questionnaire that, again, I would love for you to fill in. And if you have any questions now or in the future, you're welcome to contact us. You could see our contact info on the PowerPoint. And thank you very, very much. Amasaganalo. And we hope to see you next week.
Thank you. Thank you so much.
You're very welcome.